Anjugam?
Sir. Good evening, sir.
Good evening. Iதை share பண்ணி பாப்போம். Share ஆகுதுல்ல?
Sir, ஒரு நிமிஷம் sir.
முதல்ல PPT முதல்ல ஓபன் பண்ணி வச்சிருவோம் இதுல. ஓபன் டெஸ்க்டாப்ல லேப்டாப்ல ஓபன் பண்ணிட்டு இதை மினிமைஸ் பண்ணிக்கமா, ஜூமை மினிமைஸ் பண்ணிட்டு அதை ஓபன் பண்ணிட்டு.
Okay. Sir, தெரியுதாங்க சார்?
தெரியுது. ஓகே. இப்போ க்ளோஸ் பண்ணு. அவங்களையும் ஜாயின் பண்ண சொல்லு.
ஓகே சார்.
நம்ம செக் பண்ணிடலாம்.
ஓகே சார். சார், இது மீட்டிங் ஜாயின் பண்ணுங்க சார். ஸ்கிரீன் ஷேர் ஆகுதான்னு ஒரு டைம் சார் செக் பண்ணணும்னு சொன்னாங்க சார். ஓகே சார். Hello. Join the meeting. Okay. Sir wants to check once. That's all. Okay. Sir, ரெண்டு பேரும் ஜாயின் பண்றேன்னு சொல்லிருக்காங்க சார்.
ஜாயின்?
சார் ஜாயின் பண்றேன்னு சொல்லிருக்காங்க சார். ஜாயின் பண்ணிட்டு இருக்காங்க
சார். தமிழ்மணி சார், இல்ல அன்மியூட் பண்ணுங்க. Emma, Ravina?
Yes, sir.
Just there is no light in your face.
Yes, sir.
Face look dark. Just share. Balaguru, just share. I think I will. Okay. Balaguru, share your. Just you share, Ravina.
Yes, sir.
Yeah. Yeah. Okay, ma. You stop sharing.
Yes, sir.
Ask Balaguru to join. Yeah. Okay, ma. ஏம்மா பேர் என்ன அஞ்சுகம்
sir.
உன் இதுல அந்த கீழே ஒரு பட்டன் இருக்கு பாரு, ஷேர் ஸ்கிரீனிங் பக்கத்துல ரெக்கார்ட் பட்டன் வருதா?
வருதுங்க சார்.
அதை கிளிக் பண்ண என்ன என்ன வருது?
Record on this computer, record to the cloud ன்னு வருதுங்க சார். ரெண்டு ஆப்ஷன்.
அதை நான் ஸ்டார்ட் பண்ண உடனே நீ ஸ்டார்ட் பண்றதுக்கு முன்னாடி அதை ரெக்கார்ட் போட்டுறேன்னா?
ஓகே சார்.
ஓகே. We'll exactly start by 6 o'clock. Okay.
Okay, sir.
Sir, Tamilmani sir.
Sir.
Exactly 6 o'clock start பண்ணிடுவோம். Okay.
Sir, கூப்பிட்டீங்க?
இல்ல நீங்க இதுல இது பண்ணீங்களா உங்க ஐஎம்ஏல? சரி சரி. இல்ல இல்ல ஜஸ்ட் அவங்களுக்கு கேட்கலனாலும் என்னைக்காவது கேட்பாங்க. கேட்கலனாலும் நம்ம முகமாவது அடிக்கடி தெரியும்ல. ஐயோ ஐயோ நான் இது ஆடி
Good evening, sir.
Well,
You will start.
Yes, sir.
So, good evening, friends, and all the office bearer of IAP-Tiruvannamalai district branch, and our dear faculty members, Dr. Anjugam, Dr. Ravina, and Dr. Balaguru, and also our President, Dr. Tamilmani sir, and our patron, Dr. Karunanidhi, and also our Treasurer, Dr. Satish Kumar. I think this pediatric dermatology, not only pediatric dermatology, everyone needs skin care. I think many times, I think past few years, I used to go to dermatology OP and ask our dermatologist, Dr. Anjugam, what is the best soap or what is the best shampoo? She tell so many answers. So even now, although I have some idea, nowadays, previously I used to write some Dove baby soap, or now I started writing Safamed. I think that is the best one. I don't know. So everyone need, we every day use some shampoo, some powder, okay, some conditioner, some moisturizer. I think it is high time we should know what is the truth. There are hundreds of, thousands of products available in the Ayurvedic product, this product, homemade one. And also, every day we face many pediatricians. Somehow I manage with some steroids, some antifungal, okay, some coconut oil. I think so. Many dermatologists those days use coconut oil, okay, for many things. Maybe it's a natural moisturizer or something, okay, lubricant. So, with this in mind, we have started this pediatric dermatology symposium. All the speakers are from my own institute, that is Arunai Medical College, Tiruvannamalai. It's a small town, actually, it's a rural area. With these few words, I request our patron, Dr. Karunanidhi, to say a few words. Karunanidhi, sir?
yes, sir. Good evening, sir. All the participants. It's a good initiative to our branch. We will continue further CMEs like that. Okay, sir. Continue.
Okay. Satish, you are there? Okay. Dr. Kumaresan?
Sir, I'm here, sir.
Dr. Kumaresan? Kumaresan? Yeah.
Hello, sir. Yes, sir.
Yeah, Kumaresan.
Yes, sir.
Yeah, you can unmute your video also. Video?
Yes, sir. Yes, sir.
Yeah. Now I request our today's chairperson is Dr. Kumaresan. He is our actually he is a pediatrician come general medicine specialist actually. Actually, he is my student in 1994 in Institute of Childhood, Chennai. He did DCH. And also, I think he served in many government institutions. I think he did 2002, I think, in General MD, and also when acquired various positions. And also he is a member of IAP, IMA, and other organization. Now he is our, after retirement 2 years back from the government service, now he is Professor of Medicine as well as HOD Emergency Medicine. I request Dr. Kumaresan to chair this session.
Thank you, sir. Good afternoon, good evening to all participants. First of all, I have to thank my respected teacher and professor, Dr. Gunasingh sir, Dean, Arne Medical College, and HOD Department of Pediatrics, and Secretary, IAP, Tiruvannamalai District. And I have to thank Dr. Tamilmani sir, President, IAP, Tiruvannamalai District, and also office bearers, all the office bearers for having given this opportunity to me. And this is a symposium from dermatology, on dermatology, from Department of Dermatology, as well as Department of Pediatrics, Arne Medical College. The dermatology titles are very essential nowadays. The given titles are 3 persons are going to talk about dermatological issues. The first topic is day-to-day skin care, particularly from pediatric to geriatric. That is really very essential. Nowadays, people spend more money on skin care, even then not satisfied, and thinking that where to get information, is it right for me? Really, how to use for that skin condition, either dry or oily skin, whichever it may be. But as far as the title is concerned, it's not a new one. Even then, for example, saffron is being used, ingested, taken by in mother. What for? It is actually the better color of the fetus or the newborn to be delivered. So many centuries back. At the same time, the title goes to geriatrics. Really, when I was in my childhood, I have seen my grandmother and grandfather. They were applying coconut oil after taking bath. Really, in the older age group, dry skin and the pruritus, other things are really worrisome, and without any disturbances, they were applying coconut oil. Really, the title is very important, particularly the need, even though the dermatology has gone into various directions, this is essential one. And this is another title is pediatric dermatology, non-common skin conditions. And another one is pediatric trichology, common hair disorder. This is also really, which is more worrisome for certain age group, even the adolescents and the marriage age group. So it is very, very essential topic, and it's being to be discussed here. And over to Dr. My teacher, Gunasingh sir.
Okay. Thank you, Dr. Kumaresan. Now we will, I introduce Dr. Anjugam. She is assistant professor in our Arunai Medical College. He did UG in Madras Medical College and PG in Guru Gobind Singh Medical College. He is a university topper and gold medalist in PG. So over to Dr. Anjugam for presentation of, pediatrics to geriatric skin care. Emma, short sparing. Did you record it on your computer also?
Sir, I'm recording.
Okay. Start sharing the screen.
Okay, sir. Is it visible, sir?
Yeah.
Yes.
Anybody want to ask any question? You can put it in the chat box. At the end of the session, we'll try to answer the question.
Thank you, sir, for the opportunity. Good evening, everyone. Today we are going to see about day-to-day skincare from pediatrics to geriatrics. First of all, why do we need cleansers? Cleansers are the surface active substances which lower the surface tension over the skin and remove the dirt and other microbes over the skin. An ideal cleanser should do all these actions without damaging the skin. At the same time, it should retain the moisture of the skin surface. Cleansers are composed of water, surfactants, moisturizers, lather enhancers, and preservatives. Soaps are composed of long-chain fatty acid alkali salts with a pH of between 9 to 10. There are various soap subsets like glycerin bars, superfatted soaps, deodorant soaps, scented bars, and comb bars. Cleansers can be either lipid-free cleansing lotions or liquid body washes. Mainly, these lipid-free cleansers can be used in case of sensitive and dry skin. As such, soaps can cause after-wash tightness, skin irritation, and contact dermatitis. So, among the available soap subsets,
all other participants, please mute your mic. Okay. Even video also you can mute. Only speaker. Okay.
Among all the available subsets of soaps, synthets, that is synthetic detergents and lipid-free cleansers have the least irritancy potential. This is an Indian study in which 31 cleansers available in the Indian market were compared using a 24-hour patch test. In this, for each soap, the erythema score and the scaling score were done. To conclude, in the study, 4 products, namely Cetaphil cleansing lotion, Aquaderm liquid soap, Dove bar soap, and Aloe vera moisturizing body wash, proved to be having the least irritancy potential. These 4 products had pH over the acidic range, that is from 5 to 6, whereas all other soaps had pH ranging from neutral to alkaline, that is from 7 to 9. Among the alkaline soaps, the commonly used soaps such as Hammam and Nature Power soaps were also there. So all those soaps are alkaline soaps and it can cause dryness, particularly in elderly and atopic children. But whenever any patient asks which soap to use, it is advisable for each patient to test separately, because even like hypoallergenic products like Sebamed or Cetaphil can be allergenic to some people also. So for each, depending upon the individual, they should use one product, and whether it is suitable for them or not, it should be seen. Then moisturizers. An ideal moisturizer should reduce and prevent further transepidermal water loss. It should restore the lipid barrier of the skin, should be hypoallergenic, non-sensitizing, fragrance-free, and non-comedogenic. My ideal moisturizer should be absorbed immediately, providing immediate hydration. It should be cosmetically acceptable and affordable too. Emollients are used in mainly dry skin and papillosquamous disorders. It can be composed of cholesterol, squalene, fatty acids, and fatty alcohols. Ceramides can be used in children with atopics. Humectants consisting of urea, glycerol, and alpha hydroxy acids can be used in case of xerosis and ichthyosis. Occlusives containing petrolatum and silicones can be used in xerosis and atopic dermatitis. These are the various molecules classified under each emollient category. A moisturizer mainly maintains the hydration of the skin, but apart from that, it has many properties like anti-inflammatory, anti-mitotic, which is useful in case of psoriasis, antipruritic, which is useful in case of atopics or senile pruritus or other pruritic conditions. It has photoprotective action also. Because of the antimicrobial property, it helps in wound healing also. And moisturizer should be used whenever there is low environmental temperature, low humidity, or any exposure to chemicals. In aging, eczemas and other disorders of keratinization like ichthyosis, to maintain skin integrity in special populations like atopic and elderly. Ideally, a moisturizer should be applied immediately after bathing, preferably within 3 minutes of bathing, when the skin is still moist, without wiping the body dry. When it is still moist, it is preferable to apply the moisturizer in adequate quantity all over the body and face. Then oils, there are so many mineral and vegetable oils available. This is a study which compared all the plant oils available. In this, it showed that lipid penetration was higher for olive oil, followed by coconut oil, grapeseed oil, and avocado oil. Topical applications of these linolenic and linoleic acids helped in closure of surgically induced skin wounds, and omega-9 fatty acids induced faster wound closure when compared to omega-3 and 6. And these oils have various properties like anti-inflammatory, which helps in preventing skin aging and actinic keratosis, antioxidant property, antimicrobial, antibacterial effect, which helps in wound healing. Colloidal oat extracts exhibit direct antioxidant and anti-inflammatory activity. Mainly, this colloidal oatmeal extract is incorporated in moisturizers replicated for atopic children, and also ceramide containing moisturizers. Coconut oil has been shown to be as effective and safe as mineral oils when applied as moisturizers for mild to moderate xerosis. Coconut oil is the most effective and the cheapest emollient available. So whenever if patient is not affording for any moisturizer, it's always better to use coconut oil on regular basis. Coconut oil also has bactericidal, antifungal, and antiviral properties. Moving on to sunscreens. The effect of sun exposure is affected by so many factors. Like sun exposure is mainly during the 9 a.m. to 3 p.m. and also maximum during 11 a.m. to 1 p.m. So it's better to avoid sun exposure during these times if possible. Then obviously sun exposure is more during the summer times, but it doesn't mean that during winters we can go out without applying the sunscreen. Because though the sky is cloudy, still the UV rays can come down, because only high, thick, uniform cloud can prevent the UV rays, whereas the scattered clouds can still allow the UV rays. So it is always better to apply sunscreen, either it is summer or winter, it doesn't matter. Then with respect to clothing has various factors, will be discussed in the following slides. Then whenever we go to high altitude, there are more chances of sunburn, because people think in high altitudes there won't be sun exposure, but actually for every 1 kilometer rise in the altitude, there is a chance of 20 to 25% increase in the sun exposure when comparing to the Earth's surface. Then these are components of the UV absorbers. UVA absorbers include oxybenzone, dioxybenzone, and avobenzone. These are the main commonly incorporated components. UVB absorbers include PABA is the classical and very old molecule since a long time. Then cinnamates and salicylates are also UVB absorbers. Then some people can be allergic to sunscreen even. So in those people, instead of using these chemical sunscreens, physical blockers like titanium dioxide and zinc oxide can be used. Then though we apply sunscreen, it should be in adequate amount, because simply applying sunscreen will not provide protection unless it is adequate in nature. So for slightly more than half teaspoon, that is 3 ml, should be applied to each arm, to the face and neck. Slightly more than a teaspoon, that is 6 ml, should be applied on each leg, the chest and back. Using an adequate amount of sunscreen provides greater protection than using an inadequate amount of sunscreen with high SPF. For an Indian skin, sunscreen with SPF of 30 is sufficient. SPF 30 itself can prevent more than 97% of UV rays. So SPF 50 is not that much needed unless it is like any genetic condition like xeroderma pigmentosum or something. For normal skin, SPF 30 is more than sufficient. Then in children, no sunscreen should be used during the first 6 months of life. Then sunscreen should be applied 15 to 20 minutes prior to going out of the home or prior to sun exposure, and it should be reapplied every 3 hours when you stay outside. Then after like wetting or exercise or bathing something, after excess sweating, it should be reapplied. Then with respect to clothing, tightly woven thickened fibers provide more protection. Washing increases the UV protection factor of the clothes. Whenever the cloth is wet, then exposure to sun rays is more. Then fabrics prone to stretch have lower protection. Colored fabrics are more protective than uncolored ones. Then distance of a fabric, like if the distance between the fabric and the skin is more, then it provides more protection. An appropriate protection against solar exposure is required during daily activities to prevent clinical, cellular, and molecular changes that may cause photo damage, including photoaging, sunburn, pigmentation, and cutaneous malignancies. Then for hair, all the available sunscreen actives are not substantive to the hair. So it is better to use clothing, any cap or something, any like physical method to protect the hair. Then systemic photoprotection in the form of antioxidants, vitamin A, C, E, or in special conditions in porphyrias, we can use anti-malarials. Then avoiding solar exposure at times of peak intensity, using cover-up garments to cover the entire body, trunk, extremities, everything with the clothes. Then wide-brimmed hats for the scalp, and sunscreen lotions in an adequate amount with proper SPF is an effective combination for protection of the skin from sun. Moving on to hair care. Healthy hair is pigmented, smooth, glossy, and flexible yet strong, with ability to withstand shearing forces. But over several years, it can be exposed to cumulative damage from external factors like chronic UV exposure, excessive wetting, repeated chemical procedures, hot combs, or blow drying. Even simple but repeated activities such as rough combing and brushing can lead to damage of the hair. Then depending upon the water we use, that is water with a very high mineral content or tap water containing copper, all these can get deposited in the hair shaft and damage the hair. Whenever there is like more exposure to the environmental dust or every sebum and all other dirt gets accumulated over the hair, then it becomes unmanageable and it should be washed immediately. This is weathering of the hair in a natural way. Second picture is after repeated cosmetic procedures. An ideal hair cleanser should be gentle to hair and scalp, should have pleasant color and fragrance, easy to spread on hair and to rinse, should enhance the gloss and luster to the hair, should be non-allergic. An ideal shampoo should remove dirt and sebum, should be non-irritant to eyes with good foaming capacity, and it should impart shine to hair. In the olden days, mostly people used to take head bath also with soaps only, but it is not recommended anymore for hair cleaning because soaps don't have good lathering capability, and it also leaves behind soap scum, which is difficult to rinse off. So either hair cleanser or shampoo should only be used for head bath. There are various cleansers available, like components of the cleansers, which we are going to see. Out of those, the popular primary cleansers are lauryl sulfates, which are mainly used in case of oily hair because it produces more foam and it can be easily rinsed, like sodium lauryl sulfate. Whereas for normal to dry hair, lauryl sulfates are preferred. Then there are foam boosters like cocoa diethanolamide and preservatives like parabens. This table is showing the like various components with the categories given, and for like dry hair or baby hair or menopausal hair or like whichever chemically repeatedly treated hair, we should prefer amphoteric shampoos containing like the sultanes and betaines. Like for children, we used to, like atopic children, we used to give Sebamed or Spoo shampoo. All these contains betaines and sultanes. Whereas for oily hair, it is preferable to use anionic, which contains lauryl sulfates. And in whichever shampoo you choose, there will be so many ingredients given. But whichever is given in the top, those are the main components. So depending upon the nature of your hair, you can select based upon the molecules given. Then conditioners, that nowadays like shampoo plus conditioners are coming in 2-in-1. Conditioners reduce the static electricity, flattens the cuticle and reduce the friction. Then it improves shine and color. Mainly conditioners are advised for those wishing to shampoo daily and for dry or chemically damaged hair. Commonly used conditioning substances include silk and animal proteins, dimethicone, simethicone, and propylene glycol. Protein-derived substances in conditioners can temporarily mend the split ends of the hair. These proteins attracted to the keratin holds the cortex filaments together until the next shampooing occurs. Sebum is a natural conditioner for the hair. Coconut oil can penetrate the hair shaft more and it can reduce protein loss when comparing to the other vegetable or mineral oils. Then other like naturally available conditioners include egg and hibiscus. Egg contains many other nutrients also. Hibiscus is a natural conditioner and it has anti-dandruff property also. Commercially available conditioners can be in the form of instant rinses, leave-on conditioners, leave-in conditioners, serums or deep conditioners. Proper shampooing technique means first you should wet the hair completely from the scalp to the tip of the hair. Then you should take adequate amount of shampoo in the palm at once only, and you should not shampoo twice on the same, like take adequate amount in one go only, mix with water and make proper foam, then apply it over the head, then along the length of the hair, and hair should not be piled up on top of the head. Hair should be rinsed from the scalp to the tip of the hair. Then nowadays, like people tend to do hair straightening often, but it is very damaging to the hair, and even when performed correctly, it can result in loss of up to 20% of the tensile strength of hair. So loss of proteins and moisture result in dry and brittle hair. Avoid repeated and frequent sessions as damage by successive straightening is additive. Then moving on to face care. To wash your face, always use a gentle, non-abrasive cleanser. Wet your face with lukewarm water and use your fingers to apply the cleanser. Don't scrub your skin. Apply gently, like massage gently only. Rinse with lukewarm water and pat dry with a soft towel. Then always apply moisturizer after washing your face. And washing should be limited to twice a day. And you can wash your face in exceptional conditions like after sweating or any physical activity which can lead to increased perspiration. And always remove your makeup before going to bed. Then like depending, like when you have oily face, then you can use salicylic containing face washes. Then foot care. Because of ill-fitting footwear, walking barefoot because of any religious rituals, then using pointed shoes, all these can lead to thick callosities or rough skin. So use any foot scraper or a pumice stone to remove these excess callus on and off. Then nail care. As we need a moisturizer for the skin, for the hands and feet and nail also, it needs emollient cream. So after rinsing your hand and feet dry and then apply emollient cream so that the moisture will be trapped into the nail plate. Then nail polish application, ideally it should be applied in 3 layers. The first layer is base coat. It should consist of more resin content. It protects the nail plate from staining. Then over that, you can apply whichever color you need the nail polish. Then the top coat should be consisting of more nitrocellulose and a lesser resin content so that it protects the varnish from chipping. Then nail polish remover like acetone containing and acetone free removers are available in markets. Acetone free removers are preferred as acetone removers can cause contact dermatitis. Then nail cutting method. People tend to cut in a curved manner, but it is wrong technique. Nails should be cut in straight manner only, because when they tend to cut in curved manner repeatedly, there are more chances of getting ingrown nails. Then it can lead to like many complications. So it should be cut in a straight manner. Then artificial nails are available in the form of acrylic or gel based, but any nail cosmetic is not recommended in children. Nail polish should be left on for 2 to 3 days only, and it should be removed with acetone-free cleansers. Leaving it for long time or applying one nail polish over other nail polish, all these can lead to staining of the nail plate, and applying the artificial nails can also lead to nail plate damage. So it should also be removed whenever it is used for any occasion. Then most common allergen in nail polish is tosylamide formaldehyde resin. Then in newborns, lukewarm water baths with temperature less than 37 degrees Celsius are given in the first few weeks of life. But in our state, like people tend to give hot water baths, but it should be lukewarm water, not hot water. Should be usually given 2 to 6 hours after birth in a healthy term baby weighing more than 2.5 kgs. In a low birth weight infant, bathing should be delayed till the cord has fallen off. The bath of the newborn should not last more than 5 minutes. Even in children also, it should not last more than 10 minutes. Short bath should be there with lukewarm water and followed by moisturizer within 3 minutes of bath. The neonate should be bathed in a warm room and should be dried and thoroughly from head to toe, followed by wrapping in a warm dry towel, and it should be placed next to the mother. In the initial days, apply soap only to the dirty areas such as the creases and diaper area, and rinse off after cleaning. And soap should be avoided because soaps affect the integrity of the hydrophilic film of the newborn skin. It can cause protein denaturation and delipidation of the skin. Then the commonly used Syndex consist of cocaine isethionate and sodium lauryl sulfate betaines. Whether powders can be applied to the babies or not. Again, this also our people tend to apply excess powder for the babies, but ideally should be best avoided in the newborn period, because first they have to acclimatize to the external world from the intrauterine life. So excess use of powders can lead to further blockade of sweat duct pores and can lead to malaria formation. Accidental inhalation of the powder is also another potential hazard. Then for the scalp, it consists of cleansers and lather producers in the shampoos. The best cleansers are laureth sulfate, and lather producing molecule is cocamide diethanolamine. The pH of the shampoo should be close to the tears of the baby, and it should not be irritating to the baby's eyes. In special conditions like seborrheic dermatitis, other special ingredients like ketoconazole, zinc, pyrithione, and selenium sulfate can be added in the shampoos. And topical agents are best avoided to the umbilical cord. Nails should be cut and kept short and clean. Cotton swab soaked in boiled water should be used to clean the eyes of the baby, should be done in a gentle manner. And as I told earlier, during the first 6 months of life, sunscreen should be avoided. At the same time, we should also protect the baby from the sun. So for that, the best way is to keep the baby in shade. Then in elderly, already because of the decrease in moisture of the skin of the elderly people, moisturizer is more important, and it should be applied repeatedly to protect them from senile pruritus or pruritus due to any other comorbidities like due to diabetes, renal or liver conditions, or due to thyroid disorders. Avoid bath oils in elderly due to the risk of accidental fall. Then regular sunscreen use should be there, because it can decrease the photoaging in the elderly and also do periodic screening for skin cancers in elderly. Then moving on to hair dyes. Gradual hair dyes consist of salts of metals. This picture is showing the vegetal hair dye. It is a vegetable hair dye free of chemicals, ammonia and PPDs and hydrogen peroxide, but it gives a gradual coloring only. It won't give very dark black color on one go itself. But whoever is allergic to the like routinely available hair dyes, they can go for vegetal hair dye, which is hypoallergenic and PPD free. Hair dyes can be either temporary, which gets washed off in one wash itself, semi-permanent hair dyes, which last for 6 to 8 wash. Demi-permanent hair colors contain hydrogen peroxide, whereas the temporary and semi-permanent does not contain hydrogen peroxide. Permanent hair dyes require the combination of para dyes, which is paraphenylene diamine. This is the PPD component, which is commonly used in the hair dyes to give the color, along with hydrogen peroxide. Then of late, PPD is being incorporated into the henna also to give a deeper color, because henna will give orange red tint only. So when they add PPD in that, it will give black color. So it is marketed as black henna. There are several hair dyes available like L'Oreal, Garnier. Vegetable hair dyes include black rose hair dye, Khadi, vegetal and Indus Valley hair color. Henna is prepared from crushed leaves of Lawsonia inermis. It gives orange-red tint. It is a semi-permanent dye. This is the Godrej hair dye available in the market. It consists of natural cleansing agents like shikakai and rita, natural conditioner like mehendi. Amla acts as an natural hair darkener. Actually, in this in disclaimer, they have given PPD content is not more than 1.5%. According to the European recommendations, PPD content should not be more than 2% in any hair dye. Then it has more chances of causing contact dermatitis. So whenever you use any hair dye, check whether it is PPD containing or not. If it is PPD containing, the percentage should not be more than 2%. Indigo is a natural dye prepared from the crushed leaves of Indigofera tinctoria. When mixed with henna, the color results are superior and it is a permanent dye. As I told earlier, the European Commission recommends that PPD should not exceed more than 2%. Then if the individual is allergic to PPD, they should not use PPD containing hair dyes again. They can go for other dyes like semi-permanent dyes or dyes containing paratoluene diamine sulfate, metallic dyes or pure henna. Thank you, everyone. Thank you whoever listened.
Over to Dr. Kumaresan.
Thank you, Dr. Anchigam. Very informative.
Stop sharing the screen. Yeah.
Very informative, Dr. Anchigam. And really, it's more informative, particularly when you say the emollient coconut oil, very cheapest and the more useful antioxidant, anti-inflammatory, other things. And another thing, sebum itself conditioner, but sometimes seborrheic dermatitis itself causes a problem in the hair. And another information is most of the people are cutting the nail in curved manner. Sometimes more worrying that the older age group, they get ingrowing of nails, more problematic when they get the comorbidities. Really more informative. Over to Dr. Singh, sir.
Anjugam, somebody asked, Madam, recommend a few brand names for neonate and toddlers, both soaps, shampoo, and moisturizer. Because so many, although we don't seriously recommend, but there are a lot of shampoo, soaps. It is very difficult for even a doctors to go by your recommendation. I cannot carry some book in my hand and go and find out. Is it some costly soaps and moisturizer or shampoo are better? Do you think like that? Or you can tell some, maybe Safamed soap, Safamed shampoo and moisturizer are good? You just tell the answer, ma. Somebody asked.
Sir, for baby shampoos, we can use Poo shampoo or Sebamed shampoo, but it depends upon the individual only, as I said before.
Normal, hope they don't have any seborrheic dermatitis. Normal child, probably. Okay.
Normally, Poo shampoo or a Sebamed shampoo can be used, sir. Then
So-
for soaps also, scented bars preferably, sir. So either Cetaphil, Sebamed, or Moisturex scented bar, Oilatum bars. All these we have used, sir.
Okay, and there is
If
no
they cannot afford, then they can use baby dove.
baby dough. Okay, any you said shampoo and conditioner are coming together. Is it better, or you use first shampoo and conditioner later on? Combined use.
Sir, actually, I don't use conditioner, but normally we need not use. But if they wash repeatedly or if they have damaged hair, then they can use conditioner.
You said that I think herbal cartridge is better or PPD is less than 2 and other thing. Is it available in Europe also, this sekai, henna, everything, this natural one, or only in India it is available? You don't have idea?
No, sir. In Europe, I don't know.
Because you gave some recommendation, dye, that one.
Sir, for PPD, it is a European recommendation, sir. Then, to say any one product out of the products available in Indian market, when I searched, this one came, sir, with less than 2%.
Okay, ma. For diaper dermatitis, madam, somebody asked, Priya.
Sir, it will be discussed in the coming session, sir.
Okay, okay. Madam, is it hibiscus leaves or flower that are used as conditioners?
Flowers, sir.
Okay. But you can make it in your home, is it? My sister used to take some hibiscus flower, put it in oil. Is it like that? Some hibiscus, I don't know. Those days.
Sir, it has natural properties, sir. You can use.
Okay, okay. I think probably the message is coconut oil is the best for maybe panacea for all skin condition. Maybe, I don't know. Because those days dermatologists use all. I have seen one famous dermatologist in Chennai. He always write some particular brand of any particular brand. Any coconut oil is anything is okay, or only virgin coconut oil, something.
No, sir, not like that. Any coconut oil is okay, sir. Without any fragrance.
Organic.
Normal.
Many things. Okay.
Sir.
Okay, ma'am. Okay, we'll have next. We'll have Dr. Ravina, isn't it? Or Balaguru?
Dr. Balaguru, sir.
Over to Dr. Balaguru. He will talk about some skin condition in pediatric dermatology, common skin condition. I think he is assistant professor in our Tiruvannamalai Arunai Medical College, and he finished undergraduate in Karpaganagar Medical College, PG in Government Medical College, Thrissur, Kerala. Over to Dr. Balaguru.
Thank you, sir. Good evening to all. Am I audible on my slides?
Yes, yeah. Perfect.
Today, my topic of discussion is pediatric dermatology. Today, we'll be seeing these are the topics I'm going to discuss. The importance of pediatric dermatology is that about 1/3 of the dermatology OPD comprises of pediatric patients only. Most of the time, we make out the diagnosis based on the clinical examination and history itself. This table shows the difference between the adult skin and neonatal skin. The neonatal skin is still developing and it is underdeveloped. It's very thin. The thickness is only half of the adult skin. And even the collagen, elastic fibers, the dermoepidermal junctions, melanosomes, vascular plexus, everything is underdeveloped. As you can see, the last point, the permeability and absorption is more in neonatal skin compared to the adult. The classification for pediatric dermatology is mainly for physiological, acquired, genetic, and neoplastic. Mostly, I'm going to discuss about physiological and very few about others, acquired, genetic, and neoplastic. These are the physiological neonatal dermatosis: Vernix caseosa, Mongolian spot, physiological scaling, suckling blisters, cutis marmorata, miliaria, milia, neonatal acne, cradle cap, erythema toxicum neonatum, transient neonatal pustulosis. First, Vernix caseosa. It is a white thick layer covering the newborn skin. Uh, it has a lubrication property as well as antibacterial property also. But current trend is that newborn photo shoots, what we do is that we just wipe the vernix caseosa and immediately and use wipes which has chemicals and damage the skin. But actually, vernix caseosa is a protective agent and it has lubricating and antibacterial property. It advised not to wipe the vernix caseosa. The picture shows the vernix caseosa in a newborn. Next is Mongolian spot. Mongolian spot is usually seen at the birth. It can be single or multiple. It can be small with the 3 centimeter, or it can be large with 15 or to 20 centimeters. It is slate gray or blue in color. It usually subsides within first to 3 to 4 years of life. Usually seen in the lumbosacral region, buttock, shoulder, but it can also be seen anywhere in the body. It's usually isolated condition. Very rarely it can coexist with other genetic conditions, inborn errors like GM gangliosides and mucopolysaccharides. Next is physiological scaling. Physiological scaling is almost in 75% of the newborn. Usually starts in the extremities, hands and feet, and soon it becomes generalized. It's usually subsides within 1 month of the newborn. Next is suckling blisters. Suckling blisters are seen in the over the fingertips with a clear fluid-filled vesicles. It is due to the vigorous suckling. As I told already earlier that the skin of the newborn is very thin, the dermoepidermal junctions and everything is underdeveloped. So mild friction, mild to moderate friction even causes blisters. And it's suckling blisters is a self-limiting condition. Next is cutis marmorata. It is a benign cutaneous vascular condition characterized by reticulate bluish mottling of the skin. This is usually seen during 2 to 4 weeks of life. Usually most commonly seen in preterm infants. The pathogenesis is mainly due to the immature autonomic control. It is seen more during cold temperature. Next is harlequin color change. Harlequin color change, it's a transient erythema covering half of the newborn body with vertically pronounced demarcation line. Usually occurs in first few weeks of life. You can see the erythema on the dependent part of the body, and other half is contralateral. You can see pallor in the newborn. Next is miliaria. Miliaria can be classified into 3 types: miliaria crystalina, rubra, and miliaria pustulosa. Commonly called as prickly heat or heat rash. Miliaria crystalina is characterized by a small, tiny vesicles, discrete and confluent in nature. Miliaria rubra, the name mentions rubra, it is red in color. It will be an erythematous papule or pustules. Next is miliaria pustulosa. Rarely we can see pustules also, but it is a very sterile pustule. Even if you do culture or takes gram stain from the pustule, you will see no organisms. The treatment we advise is that cold water bath, ventilation, cotton cloths, and other medications. It means calamine lotion can be given If there is secondary infection, antibiotics can be given. Milia is nothing but a small superficial keratin-filled cyst. It can be seen in any age group. It usually resolves spontaneously. If it's not resolving spontaneously, we can do needling. Epstein pearl is that if the milia occurs on the palate of the newborn, it is specifically called as Epstein pearls. Neonatal acne usually seen in the first 3 months of life. It is due to the maternal hormone transfer. It is self-limiting, no need of any topical agents, just soft soap cleansing is enough. If the neonatal acne is persisting beyond 1 year of life or it is very severe, then we can suspect some congenital adrenal hyperplasia or any other virilizing tumors or androgen secreting tumors. Cradle cap is the name given for the seborrheic dermatitis of the newborn. It is a thick, greasy adherent scale on the scalp. It's usually self-limiting. First line, we advise the treatment as a warm oil application and tear-free shampoos. If it's not subsiding with this, then we go for antifungal shampoos. Even though if it's not subsiding with antifungal shampoos, then we'll go for next mild steroids. Ecthyma toxicum neonatorum, it is a benign idiopathic self-limiting eruption. It is usually seen in the first few weeks of life, within the first 1 week of life, and usually resolves within 10 to 20 days. It can be present anywhere in the body. It is usually characterized by the erythematous macules. Sometimes we can see vesicles or pustules in the over the center of the erythema. When we do cran stain from the pustules or the vesicle, we can see eosinophils. In the erythematoxicum neonatum, the child will be very active and alert. There will be no fever. Transient neonatal pustulosis is a similar condition to erythematoxicum neonatum. The only difference is that here, when the lesion subsides, there will be a mild pigmentation can be seen. This pigmentation usually subsides within a few months of life. Next topic is diaper dermatitis or napkin rash. It can be, the rash can be maybe due to urine, feces or fabrics, especially diapers, due to prolonged contact, friction and occlusion. Wetness can lead to maceration. The most commonly can have a super added fungal infection, especially candidiasis. So the first line of treatment should be treat the candidiasis, given antifungal, and then zinc oxide. We can tell them to avoid diaper or else we can tell them to apply zinc oxide before diaper application. Zinc oxide acts as a barrier cream between the skin and the diaper, so there is no contact between the diaper and the skin. And we tell them to change the diapers very frequently. Next is congenital melanocytic fever. It is present at the birth and it is classified into 4 types depending upon the size: small, moderate, large, and giant. The two main complications of congenital melanocytic nevus is that it can have a malignant transformation in the future. Second thing, it can have a meningeal involvement also. So two things should be screened. The picture shows the congenital melanocytic nevus. Nevus of phota is usually seen in the one half of the face. It is usually bluish in discoloration, unilateral. It can have skin plus eye involvement also. The skin will be blue plus the sclera or conjunctiva can also be blue in color. If it occurs in the shoulder, the name is nevus of Ito. If it's in the face, it is called as nevus of phota. It's an isolated condition. It is usually not associated with any genetic or any other birth defects. Nevus depigmentosus is usually present at birth. It is a well-defined, well-circumcised, depigmented to hypopigmented patch. Usually, no new lesion occurs after birth. The size of the lesion also grows only along with the size of the when the baby grows, so the proportion only grows. Nevus animicus. Nevus animicus and nevus depigmentosus both are same condition. Only thing pathogenesis varies. In nevus depigmentosus, the pathogenesis is due to the melanocytes. Nevus animicus, it is due to the vascular. How to differentiate between nevus depigmentosus and nevus animicus is that when we do diastrophy, nevus animicus blanches, but nevus depigmentosus doesn't blanch. Diastrophy is nothing but a transparent glass slide. We just press over the screen. Next is Becker nevus. It is usually seen in the adolescent period. It is seen as an irregular, large, hyperpigmented macule. After 18 or 20 years, sometimes hair can develop from the Becker nevus. Hemangioma is the most common vascular nevi of the childhood. Today I'm only going to, it's a very vast topic. Today I'm going to speak about only two things: congenital hemangioma and infantile hemangioma. Congenital hemangioma is that it is already developed prenatally inside the womb itself. At the birth itself, it is fully developed. But in infantile hemangioma, the hemangioma starts to grow or appear only after birth. Infantile hemangioma grows till 1 year of age, and after 1 year, it usually starts to regress in size. But congenital hemangioma, it can either rapidly involute or it can either stay as such or have a partial response also. The treatment for hemangiomas is systemic steroids, oral propanol, surgical excisions and lasers. Recent years, topical timolols are used in small hemangiomas. Solomon patch, it is otherwise called as stroke bite or otherwise called as angel's kiss. It is usually seen as a pink flat lesion, mostly seen in the globular region or nape of neck. It usually resolves completely within first year of life. Port vein stain, it is otherwise called as nevus flammus. It is present at birth. It is usually unilateral in distribution. At birth, it is only flat. As the baby grows, after 10 years or 15 years, we can see nodularity over the surface of the port vein stain. Isolated condition, but very rarely it can be associated with genetic conditions like Sturge-Weber, protease syndromes, etc. And baby comes to stain, the ocular examination should be done to rule out glaucoma. It shows the protein stain, which is very strictly unilateral, never crosses the midline. Some adolescent dermatosis. The most common conditions are acne, dandruff, striae, pseudo acanthosis nigricans, contact dermatitis, and hyperhidrosis. Dandruff is the most common condition affecting the scalp. The costly organism is malassezia. Usually, line of treatment is antifungal shampoos can be given, and it can be slowly tapered off. Striae occurs usually mainly during puberty times. It can occur over the back of the trunk also, the first picture shows. Not only usually seen in the plexus like axilla or thigh, it can also be seen in the back of trunk also. It is normal. Pseudo-acanthosis nigricans is usually associated with obesity. We can see velvet hyperpigmented seen in the flexures, nape of neck. Next is child abuse. You can find child abuse through bruises, traumatic alopecias, vaginal tears, anal tears, and STI infections. Next is pityriasis versicolor. It is otherwise called as tinea versicolor. It's an fungal disease. It is caused by malassezia. In children, it's usually seen in the face, and it can also be seen anywhere in the body. It usually the word pityriasis versicolor means scaly. Versicolor means different colors. So it's always tinea versicolor is not only white color, can also be any other color can also be seen. Even it can be black color, hyperpigmented also. It usually starts as a small macules, then it slowly increase in number and increase in size, and slowly they join together to form a larger lesion. They usually have a polycyclic border, which is very characteristic, and you can see some fine briny scales on the surface. When you do KOH mount on the fine briny scales, we can see spaghetti meatball in the microscope. Usually responds to topical antifungal. No need for any oral antifungal. It usually responds within 2 to 4 weeks of antifungal therapy. The main complication is that tinea versicolor is that can have recurrence. Second thing is that even though the fungus goes, the hyperpigmented patch can stay there. The white color patch can stay there for few months. Then only it subsides. Next is impetigo. It's a bacterial infection usually seen in preschool children. The most common organism of Staph aureus or Streptococci. It is of two types, impetigo contagiosa and bullous impetigo. Impetigo contagiosa is it is characterized by starts as a small vesicle, immediately breaks to form a honey-colored crusting. And in bullous impetigo, we can see a large intact bulla. After 4 or 5 days, it breaks and forms crusting. Almost all impetigo, they will respond to oral penicillins. My final slide, the difference of treatment between the pediatric and adult patients. Conservative management is best. Try to avoid off-label medications. And surface area of in children is more compared to adults. And the topicals we give have more absorption. And least effective dose should be used as a first line. If it's not responding, then slowly titrate. And do not use any agent which can affect the growth or which can affect any other organs of the baby. Thank you.
Thank you, Balagur, for your lucid presentation. Dandruff duration of treatment. Somebody asked Priya. Dandruff duration of treatment, she asked.
Dandruff, we can give thrice weekly for first 4 weeks. And then next 4 weeks, we can slowly taper to twice a week. And next 1 month, we can give once a week. And then we can stop from 4th month. There should be slow tapering.
Okay. Somebody asked what talcum powder to prescribe for malaria. I think malaria is
usually, we never prescribe talcum powder. We just tell them to apply calamine lotion, loose clothes, ventilation, air.
Okay. So over to Dr. Kumaresan. Kumaresan? It's not there.
Yes, sir. Sir, yes, sir. Yes, Balagur has nicely discussed the.
Balaguru, stop screening. I mean, sharing the screen. Okay.
Okay, sir.
Yeah, go to Kumaresan.
Yes, nicely discussed, particularly the neonatal, newborn conditions. That is more sensitive area, particularly for pediatrician, newborn, neonate. The person will come with 2 or 3 persons at least to the clinic. They will be more sensitive to explaining and what to say is most of the times reassuring. Other things is very difficult. Really, the pediatrician should know these neonatal and newborn conditions. Other than these things, well, nicely discussed, Balaguru. Over to Dr. Guru Singh sir.
Eba, somebody asked for hyperpigmentation in face in adolescent treatment. Priya, hyperpigmentation patches.
It's very first we have to identify what is the hyperpigmentation and why it has occurred. Then only we can tell about the treatment, sir.
Oh, okay.
Because I have already told tinea vesicular can also be hyperpigmented.
Okay,
And
color TV. Yeah. Okay, depend upon the etiology.
etiology is
Diaper dermatitis, Nikhil Sanjeev asked hydrocortisone cream percentage and duration and tapering dose.
sir, usually for infants or newborns, we usually don't give steroids. First line of treatment will be antifungal to for the superadded candidiasis. Then we'll give zinc oxide. If it's not responding to that, then last it's a topical steroid.
Maybe 3 to 5 days. I think 2-3 days it goes away if you put steroid cream.
Yes, sir.
Maybe
Maximum
there is no need
for
to
5 to 7 days, sir.
Okay.
After that, it's not advisable.
Vasanthi pediatrician, pityriasis alba treatment.
Pityriasis alba and pityriasis versicolor are usually similar looking. Both occur on the face. Both are white in color. The difference is that pityriasis alba can be erythematous to hypopigmented and it doesn't have a well-defined border. But in tinea vesicolor, it has a well-defined border. And both in tinea vesicolor, scaling will be more. Tinea alba doesn't have scaling. Pityriasis alba usually subsides with emollients.
Emollient cream. Okay. But usually those days we used to give deworming, iron, calcium and all because, Another Vijayalakshmi, Bhimareddy, any risk of using sunscreen for prolonged periods in children, doctor? Sunscreen in children. Prolonged use.
Only thing is, it is safe, but only thing is vitamin D.
Do you use actually Anjugam? Okay.
Sir.
Yeah, what is I wanted to ask you, sunscreen, we were talking so much. I think I see a lot of Westerners using. We go in hot sun. Actually, we never use, is it harmful or only people sensitive skin we need to use? I have never used.
Not like that, sir. For everyone, it is good to use moisturizer and sunscreen on regular basis, sir. It prevents photo aging.
I see. Anyway.
But it is very costly. It is very costly, sir.
Yeah, if India 130 crore people start using, I think there is no end to it. Anyway, any role of Atarax cream in Atricaria hives in children? Local Atricaria, Atarax cream available. I don't know.
Usually oral antihistamines are best, sir.
Okay. These few words, thank you once again, Balaguru. And over to Ravina Naik. Please start sharing the screen.
Yes, sir.
Yeah, is going to talk on pediatric trichology.
Good evening, everyone. Thank you, Dean sir, for giving opportunity to be the part of today's symposium. So I'll be talking on pediatric trichology. That is, the trichology is a branch of dermatology which deals with the hair and the hair disorders. So today I'll be talking the common hair disorders which are seen in children. So many a times the parents are more concerned that my child is experiencing a lot of hair fall, the hair is not growing, hair is becoming dry, there is a patchy hair loss. So we need to know the causes behind it and whether patient needs the investigation, whether the child needs the treatment, and how to go about it. So most often when the child presents with a hair loss, it is most often a benign and a self-limiting condition. And the most common causes which are seen in children are non-scarring alopecia. And it includes the conditions like tinea capitis, alopecia areata, trauma due to traction or trichotillomania, telogen effluvium. Sometimes in childhood, you can get the scarring alopecia, and basically the scarring alopecia needs the evaluation in the form of scalp biopsy, and thus the referral to the dermatologist is must. So alopecia in children can be characterized as disorders of hair and aberrant hair growth, hereditary and congenital alopecia, sometimes hair shaft abnormalities. It could be traumatic alopecia, and last, the infections of the hair. So the most common infection where the patient or a child can present is a tinea capitis. It is basically the fungal infection of the scalp and the hair, which is caused by dermatophytes. The most common species causing tinea capitis include Microsporum and Trichophyton. Mainly the child will present with the scaly patches of alopecia or patches of alopecia with the surface showing the black dots. Most common symptoms will be the pruritus and the hair loss. In case of inflammatory cases where there is a secondary infection, you can get cervical and occipital lymphadenopathy. Sometimes children can act as a asymptomatic carrier and they will just have scaling on the scalp, which may be missed by the parents and even by the child because of asymptomatic carrier stage. So this is the first presentation of the tinea capitis one can get, which is most common. It is a gray patch tinea capitis. Here, the patient can present with a single or sometimes multiple scaly patches of alopecia, and these patches will enlarge over a period of weeks to months. In this picture, you can see there is a diffuse involvement of the scalp hair in the form of a scaly plaques. The second type is a black dot tinea capitis. Here, there is a well-defined patch of hair loss. If you can see the surface, it is studded with the black dots. So these black dots are nothing but they are the hair follicles which are broken. The next type is an inflammatory type of tinea capitis, that is a carry-on. So patient will present with a plaque or a boggy swelling with a superficial pustules on the surface. There will be lot of crusting, sometimes lot of oozing, and on palpation it will be tender and painful. These cases usually because of lot of secondary infection and inflammation will present with a cervical and the occipital lymphadenopathy. So here you can see the matting of hair here and lot of crusting which is stuck to the surface. Another type of inflammatory tinea capitis is a fevers. Here the patient will present with a perifollicular erythema, and if you can see in this picture there are crusting which are cup shaped. These cases of fevers are mainly endemic in Kashmir region and not commonly encountered rest of India. So the risk of both carry-on and fevers is that they are prone for scarring alopecia. So if not treated at time, then the risk of scarring alopecia and permanent hair loss is there. So in this picture, you can see the first picture, the child have a diffuse hair loss. There is no scaling, but all hair are broken. This is a black dot tinea where you can see the surface black dots. And the last picture is showing the carry-on where you can see the matting of the hair and lot of crusting and oozing with the inflammatory plaque. So diagnosis is mainly clinical. In some cases, you can go for a KOH mountain culture, especially the cases you start on oral antifungals and they are not responding to treatment to know the species because some species are resistant to the first line agent. So treatment should be start once the clinical diagnosis is made. One need not wait for the fungal culture reports. Topical antifungals are not usually effective because they do not penetrate the hair follicles. In a few, if the patient is presenting with a carry-on, then ketoconazole 2% shampoo or cyclopirox shampoo can be given to prevent the secondary infection and matting of hairs, but they will not cure the infection. So oral antifungal treatment is required for tinea capitis, and griseofulvin is the first line of agent. It is given in the dose of 20 to 25 milligram per kg per day for 6 to 12 weeks. Suspension as well as oral tablets are available. Alternative to griseofulvin is terbinafine. Mainly terbinafine is preferred in the favors cases over the griseofulvin. Laboratory investigation and monitoring are not required because we are giving a long-term therapy. However, if the treatment extends beyond 8 weeks, then the lab investigation and monitoring will be needed. Sometimes carry-on and favors require systemic glucocorticoids because of associated inflammation. So if it is not subsiding or it is not coming in control, referral to dermatologist is needed. The prognosis of children with tinea capitis is usually excellent, and there is a complete clearance if the patients are adequately treated. However, again, we have to remember carry-on and favors, there is a risk of scarring alopecia, and it can cause the permanent hair loss. Failure to identify the diagnosis, or if there is a prolonged infection, there is a risk of irreversible hair loss. Once a child is presenting with tinea capitis, the family members and the close contact of the child should be examined, and they should be looked for presence of any tinea infection because they can act as a source of infection for the children. Given the risk of asymptomatic carrier status, family members can use antifungal shampoos for 2 to 4 weeks. The patient is advised to avoid the sharing of hair products, sharing the equipments like combs, heads, helmets, etc. Sometimes the carrier might not exist in the family, and the family might having the pet which can act as a reservoir for dermatophytes, especially the microsporum species. Coming to the next condition, that is alopecia areata. It is a autoimmune condition, and multiple factors are implicated in the etiology. Sometimes it is associated with hypothyroidism, vitiligo, diabetes. So the child will present with a patchy, as you can see in this picture, there is an oval to circular, well-defined patch of hair loss over the scalp, or it can occur on any hair-bearing area of the body. Typically, it will be a circular patch with a normal appearing scalp skin. The patchy alopecia areata, as you see in this picture and this picture, is the most common form. Sometimes the child can get a alopecia totalis. That is a complete. Sir. Sometimes we can get alopecia totalis, that there is a complete loss of the scalp hair on the scalp, and the sometimes condition can even progress to alopecia universalis, where there will be complete absence of hair on the scalp as well as on the entire body, including eyebrows, eyelashes, armpit hair as well as pubic hair. When the patient presents with a patch of a hair loss, if you look carefully for the patch, you can see this exclamation hair mark, which are diagnostic for alopecia areata. It is a hair which approximately it will be tapering, and distally it will be broad. So it resembles the exclamation mark, so called as exclamation hair, which is like mainly seen in alopecia areata. When coming to the treatment options, in children especially it is limited because of the concern about the treatment tolerability. Some advise to do the watchful waiting, as the spontaneous regrowth of hair is seen in 50% of the cases in 6 to 12 months. However, the parents will be always apprehensive about the hair loss, especially if there is more than one patch and if it is a larger than 1 centimeter. So the potent topical glucocorticoids can be given. If many patches are that not responding to the topical glucocorticoids, then the intralesional glucocorticoid triamcinolone is given intralesionally. However, the pain and anxiety associated with injection is a limited factor in the children. Other options which can be given is a topical minoxidil and topical immunotherapy. Next, coming to the traction alopecia. Here, the traction alopecia is due to the constant tension on the hair. It may be because of the hair styling or tying a tight ponytails or braiding the hair tightly or use of certain chemicals and weaving procedure. Usually, this patient will have the hair loss in the frontotemporal area as seen in these pictures, but there will be retention of the hairline. You can see in this picture, the hairline is not lost, but there is a diffuse hair loss over the frontotemporal region. Usually it will have a non-specific pattern. In this patient, parents have to be counseled about it is a reversible condition if identified early and the hairstyle or a behavior is modified. However, in the long term, if not treated, then it can cause a diffuse hair loss and traumatic alopecia. The next condition is a trichotillomania. It is basically a impulse disorder. There is a compulsion to pull or pluck the hair. Most commonly, it is seen in girls than in boys. Sometimes may present in childhood as a habit, or in adolescence, it represents a sign of underlying psychological issue. In adolescence, mainly it is associated with other self-harming behavior. Unusual pattern of hair loss. It most commonly affects the scalp, sometimes the eyebrows. So it will again present with a patchy hair loss as you see in this picture. It is been non-confluent and the peripheral hairs will be spared. Mainly the site of affection will be the patches will be seen on the child's dominant hand. So how you will differentiate between trichotillomania and alopecia areata is that alopecia areata, the patch will be well defined. It will be circular or oval, whereas in trichotillomania, it will not have a circular shape. It will be bizarre shaped, irregular, and usually in if you examine the scalp, there will be broken hair because child is trying to pull the hair, so there will be broken hairs in the trichotillomania, and the hairs will be of irregular length. Whereas in alopecia areata, it is a exclamation hair marks will be seen on clinical examination, as well as the hair length will be the same. It won't be different. So usually when a child presents with trichotillomania, as the child grows, the behavior also can be altered. Counseling the patient and the parents about the behavior modification is needed. However, if it is an adolescent, then it might be difficult because they may have underlying psychological distress, and the adolescents are usually secretive about their behaviors, so they might not agree that they are pulling or plucking the hair. So diagnosis in these cases might become difficult, and some patient might need the psychiatrist referral. So usually the treatment will be the psychological therapy and counseling about the problem and modify the behavior. If patient is not responding with the counseling and the behavior modification help, then referral to the psychiatrist in recalcitrant cases is advised. If pharmacotherapy is needed, then it is the serotonin reuptake inhibitors, antidepressants are used. Coming to telogen effluvium, basically there will be some inciting event, like there will be a long-term medical illness, there will be a stress, or a patient is on certain medication, or underlying nutritional deficiency disorder, and it will occur approximately 3 months after the inciting event. Child will complain, the parents will complain that mainly the hair ponytails length, the size of ponytail is reduced, there is a diffuse hair loss. Shedding will usually resolve in these cases in 3 to 6 months, and by 6 months onward, 6 to 9 months onward, the density will improve. However, if like beyond 6 months it continues, then it is a chronic telogen effluvium. It is usually a self-limiting condition and few treatment options exist. Basically, the parents has to be reassured about the condition, that it is a self-limiting and the hair growth will occur. Avoidance of triggers like management of the stress. If a child is on certain medication, if alternative medication can be tried. Nutritional deficiency, if underlying nutritional deficiency is there, then it has to be treated. So they have to be reassured that it is temporary and regrowth is likely. However, if it is not responding, then the minoxidil or topical therapy can be tried. These were the most common acquired condition of hair loss that the child can present. However, sometimes neonate can present with a transient neonatal hair loss. Here it is a very common phenomenon, and the neonatal occipital region is most commonly affected. However, the other areas also, you can get the bald patches. Healthy babies have been observed to develop the alopecia oval patches, mostly over the occiput, as you can see in this picture. Usually during the first 2 months of life, friction is presumed to be the cause for the transient neonatal hair loss, and the occiput is most commonly affected because of the supine position during sleeping. It is a benign course, and usually there are no accompanying symptoms, and the hair grows spontaneously. So again, the parents has to be counseled about the temporary nature of the condition. Just to enumerate the congenital causes of hair loss not commonly encountered. So one will be the nevus sebaceous of Jensen. Here the condition can present at birth or in later in life. So here the patient will have a patch of hair loss. Sometime on examination you can see it might be a waxy looking, and there will be loss of hair over that area. Usually the congenital conditions doesn't have treatment, and the patient has to be counseled about, the parents has to be counseled about the condition. Another condition is aplasia cutis congenita. Here there will be a patch or a diffuse absence of a portion of the skin. Most commonly it is localized. However, you can also get a diffuse condition usually present at birth. Another condition is ectodermal dysplasia. There are a lot of syndromes which comes under ectodermal dysplasia. It is a heritable condition. So usually there will be abnormality of 2 or more ectodermal structures such as hair, teeth, nail, and sweat gland. In addition, other tissues of ectodermal origin like eyes, ear, lips, mucous membrane of mouth, nose, or central nervous system can be affected. Usually, the child will present with a fragile curly hair since birth. The main complaint will be that the hairs are persistently short and fragile and not growing. In these cases, you have to look for other ectodermal derivatives like teeth. Sometimes you can get cone-shaped teeth or bi-shaped incisors. You have to look for other areas, hair-bearing areas like eyebrows, pubic area, underarms. Sometimes they can be scanty. They can have hearing loss. Then sometimes the ophthalmological complaints also. Central nervous system, it can present with the mental retardation or the seizures. So basically congenital and hereditary hypertrichosis and hair abnormalities, they do not have effective treatment. So counseling of the parents along with the pediatrician will be needed. So when it comes to the diagnosis of hair loss in the children, proper history from the parents is must. The key points in the patient's history will be when it started, whether the onset was sudden or gradual, whether the extent of alopecia is a patchy or a diffuse, any associated symptoms are present, like there is a mental retardation, any emotional triggers in the previous month, any other ailment, whether child had any illness in the past 3 to 4 months, associated complaints like fatigue, weight changes, look for skin and nail abnormalities. Ask for the past medical history, including chronic illnesses, surgeries, medication, any autoimmune disorder, as well as the family history of alopecia, autoimmune disease, any dermatological or psychiatric disorders. Ask for the hair grooming and hairstyle behavior. Thorough examination of the scalp is must for the diagnosis of hair loss. So look for the type, look whether it is a scarring and non-scarring. Look for the shaft if there is any abnormalities. Look for hair texture and fragility. Look for presence of pustules, scales, and erythema. Basically, clinical examination of entire body is necessary to evaluate the hair loss, including the mucous membranes and the nails. Pediculosis capitis is not a cause of a hair loss, but it is a common condition affecting the scalp. So I'm covering that also. So basically, it is an infestation of a human scalp with lice. Mainly, it will be seen in an overcrowding situation, and the transmission will be with a head-to-head contact, sharing of combs, brushes, heads, etc. So the child can, sometimes the parents can tell the child just have a itching over the scalp. Sometimes they can get intensely pruritic papules also. Some people can also complain that the nits are attached to the hair shaft and the favored sides will be behind the ear. So any child having a scalp itching and there are no nits over other areas has to be looked behind the ears, especially because that is the favored site. And some children can only present with cervical lymphadenopathy. So in this picture, you can see the nits attached to the hair shaft. So the treatment in these cases will be permethrin 1%, either in the lotion form or the rinse form. If one is using lotion, it is 8 to 12 hours contact period. If rinse is used, then it is 10 minutes. Rinse will be convenient because it is the application time is just 10 minutes. So the patient is advised basically to wet the hair, apply the lotion, then it has to be overnight application. Rinse, then after wetting the hair, apply the rinse for the full hair. Keep for 10 minutes and then wash. With a small toothed comb, the hair has to be combed when still wet, and repeat application after 7 days. Other options are malathion carbaryl, but are not commonly available and prescribed. Topically also, ivermectin can be used in the 0.05% strength. Cannot be used in children less than 6 years, mostly available as a shampoo, so it can be used as a rinse only. Oral medicine which is available is ivermectin, can be used about 12 years of age. Contents of the patient should be checked and treated. Combs, hair brushes and clothes should not be shared. So basically, to conclude, it is uncommon but an important presentation in general practice. Alopecia can be focal, diffuse or pattern. A number of conditions cause significant morbidity and contribute to significant psychological stress for patients as well as parents. A systematic approach to the assessment, including thorough history, full body examination, investigation guided by presence of clinical presentation, leads to the accurate diagnosis and early referral to appropriate specialists. Treatment of typical cases of tinea capitis with oral antifungals is indicated in general practice. Consider referral to dermatologist if diagnosis is unclear, treatment is failing, or if there is an evidence of scarring alopecia. Thank you.
Sir? Sir?
Guna Singh, sir.
I'm Dr. Kumaresh. Yes, sir. Hello? Can you hear clearly, sir? My voice?
Yeah, voice is okay, sir.
Okay.
Audible.
Yes, sir. Ravina Nayak widely discussed about common hair disorders and nicely discussed. And another thing, particularly alopecia areata, that is one really when the more sensitive as in relation to the parents at mindset of counseling. This is difficult. At the same time, the area more sensitive scalp. This is all gorgeous or not. When it's alopecia areata occurs, in either few sites are widely very difficult to treat. As I said in the slide, it's 50%, 6 to 12 months, it will be spontaneous regrowth of hair. But what happens when other 50% really they come to the normal status or not?
So usually the 50% will regrow in 6 to 12 months. Rest 25%, they say 2 to 3 years it can. But if there is an inflammation and if there is associated, like if there is a more than 1 to 2 patches and all, then patient needs the treatment, sir.
They may left with a few patches permanently sometimes. What percentage could be?
Sir, alopecia areata usually is a non-scarring one. So permanently they will not remain with the patches of hair loss. However, if patient is developing alopecia totalis, if other hair starts losing, other body hair starts shedding, then patient should be given systemic steroids or other medications.
Okay. And thank you, Ravina Nayak. Very well discussed and widely discussed and nicely discussed. Okay. Over to Dr. Tamil Mani.
Yeah. Tamil Mani sir, you want to ask any question?
I wanted to ask the conjugum, the silver salts containing soaps, where it is used.
Anjugam?
Sir.
Silver salt.
Containing soap.
Usually we don't advise, sir.
Okay. Fine.
Okay. So vitamin D and sunscreen, inverse relation. I don't know, because when you go in the sun, you get vitamin D. I don't know why you want to Yeah. Any
Sir,
answer?
he wants to say, like, when we use sunscreen on regular basis, we may develop vitamin D deficiency. So,
Okay. Oh.
yes, written.
Is it true?
Sir, like, it is still, as he said, it is still debatable only. But
Okay.
as such, we have low vitamin D, and like protecting from sun can also be a reason. But usually, once or twice a week, exposure to sun itself is sufficient for vitamin D production.
Because we don't use our population is very poor. We cannot afford to. Maybe government should bring some free sunscreen scheme. Otherwise, we will never use it. Even I have not used. I think sometime back, somewhere they said it's so hot. I think when I went to Andaman, but I thought it is very not comfortable with that. I never used that because somebody gave some free sample. Otherwise, I would not have used. Fungal infection of nail and toe treatment, madam. It is once again grisophil. Yeah. Fungal infection of the nail and toe. And another thing is Balagurus are approached to hyperhidrosis in adolescent. Anybody want to answer?
Fungal
Approach to hyperhidrosis is that the hyperhidrosis can be primary or secondary. It's either focal or generalized. If it's primary, there will be no cause. If it's secondary, it can be due to drugs, especially psychiatric drugs, diabetes, thyroid disorders, and any CNS pituitary tumors can cause hyperhidrosis. But usually we see focal hyperhidrosis in palms and soles. We give only aluminum chloride salts for palms and soles.
Ammonium?
Aluminum chloride.
Orally.
Chloride.
No. Application. Local application, sir.
It's a local application. It's available in a gel or it's like a liquid form.
How many hours it will control?
It can be applied tedious. It's no need to be washed off.
But maybe a lifelong one. Primary means a lifelong he has to use it.
As a either we should first see whether it's generalized or localized. With generalized, aluminum chloride crystals are never works. It's a topical agent. We have to go for a systemic agents like anticholinergic and try to see.
Thing is, whether he can go lifelong, that is a thing, because there are so many adolescents coming and even they cannot hold the pen sometime. I said, and I think because it is not a one day event, no, it is a primary one. If it is,
can it be used only during exam times?
Yes, sir. For acute short time, we can use anticholinergic.
Okay, another thing is minoxidil percentage in children, male, female. Is it really works? I think those days we used to, even for old people like me, they used to put minoxidil, but never, hair never grown. The company has grown very taller, no? So you comment on from panelist. Does minoxidil work at all? Somebody wanted minoxidil percentage for children.
So usually in children, minoxidil is not used, but if telogen effluvium cases are not responding, then 2% minoxidil can be used, both males and in females.
Oh, okay. Okay, pityriasis alba, any risk of using sunscreen for prolonged periods in children, doctor? Risk of sunscreen, any malignancy or anything?
Sir, usually during infancy, sunscreen should be avoided, sir. Later, like in younger children, we give whenever there is any indication, sir. Otherwise, from adolescents, they can use regularly.
Okay, because recently one popular brand, they banned actually because of the risk of cancer. You know, you all know the powder, talcum powder. It was famously a lot of advertisement. Ivermectin dosage and duration, Dr. C.P. Selvakumar, I think 0.12, isn't it? single
Sir,
dose?
200 microgram per kg dose can be used, 2 doses to be given 7 days apart.
Okay. For even scabies, it can be used. Pediculosis.
Yes, sir. Scabies also it can be used.
Conjugum to everyone. Acute. Okay. Some suntan treatment, madam. Suntan. So Anjugam has replied, in acute stage, if there is more inflammation, steroid can be used for a short time. Otherwise, symptomatic treatment, calamine lotion, prevention of further sun exposure, and regular use of adequate sunscreen will improve the condition. You said something, Anjugam, even low temperature, you wanted to use something, isn't it? I was, what is that?
Yes, like people think like in winters we need not use like that, sir, whenever it is cold. But it is opposite, sir. During that time only we should apply more moisturizer.
Oh, moisturizer. Okay. Right. Winter
Sir,
and
I'm accommodation, yes, sir.
yeah.
So Anjugam, doctor.
Sir.
Yes. What percentage of the OP or the census wise the sunburn or photosensitivity occurs? Because as Sir said, we are not using any sunscreen on a routine basis, particularly. Even then, the rare occasion also. But even then, really genetically increased or relatively increased resistant to these things. Is there any like that? What percentage do you get?
Sir, actually, sunburn is more common in white people, sir. In Indian skin, it is more prone for tanning only. Here, mostly we see like polymorphic light eruptions and photodermatitis. Like 1 in 10, at least we can say, sir.
10% of people you say
mostly mostly daily at least any one patient of PML is coming, sir. Like polymorphic light eruption.
Any volume of exposure or duration of exposure in a day which predicts or which makes really need sunscreen to be advised. Am I clear?
Sir, like yes, sir, clear only, sir. Like whenever the sun exposure is at the peak, mainly as I said, from 11 a.m. to 1 p.m. it should be avoided, sir. Mostly that exposure only causes lesions.
Okay.
Okay.
Because even 10 minutes, I go sometimes from my quarters to office, at least for 10 minutes I walk. Even Dr. Kumaresan walked to office for 10 minutes. Do you think even to minimum 10 minutes or 15 minutes you need to use sunscreen, or depends
like if we are going in peak sun, it is advisable to use, sir. But if it doesn't mean that like if we go for even 5 or 10 minutes, we can develop. But if we develop the lesions once and if we have hypersensitivity, then there is more chance of recurrence of light eruption, sir.
Okay, ma. Another thing is, what is the SPF you recommend for children, madam? Sunscreen.
Sir, 15 or 30, sir. 30 is more than sufficient.
Even for adults, isn't it?
Like SPF 15 will prevent 94% sun exposure, sir. SPF 30 will prevent 97% sun exposure.
So more and more SPF, more costly, isn't it?
Yes, sir.
Yeah. Hypopigmentation due to
If it is, if they are not affordable, then calamine lotion is like the cheapest physical blocker we can give, sir.
Oh, calamine lotion. Okay.
Yes, sir. It contains zinc oxide, sir.
Okay. Hypopigmentation due to topical steroids approach. You prolonged use of topical steroid may due to the hypopigmentation. You want to any approach? Enema? And
no, sir. Like because of the long use of steroid, it can lead to hypopigmentation, atrophy, telangiectasias, like that, sir. For first we should stop steroid, then we have to use repigmenting agents, sir. Like tacrolimus or topical vitamin D analogs, like that, sir.
Okay. This is secondary to this one. Okay. Madam, use of electronics like headset or headphone can cause any hair loss.
As such, use of electronic headset or headphone won't cause hair loss, but if it is used too tightly, then it can cause traction, or because of the friction, it can cause the breaking of the hairs. Otherwise, it will not cause.
But if you increase the volume, you may lead to hearing loss. I
Hearing loss.
think.
Hair loss, it will not cause, sir.
Okay. So there are no more questions. I think it's a wonderful interactive lecture. We a lot of questions and I think answered nicely. Once again, I thank our IAP TNSC, all office bearers, Dr. Suresh Balan, Dr. Tirumurugan, and all the office bearers. Also our president, vice president, Dr. Prabhagar, and our Satish and Dr. Karnanidhi. And also our speakers, Anjugam Balaguru and Ravina Nayak, and all the participants for the excellent interactive session. Thank you, one and all.
Thank you, sir.
Thank you, sir.